Good evening. I welcome you all to another important session of webinars, that is a masterclass, which are being by Yashoda Group of Hospital. So today also we are discussing important topic, that is acute liver failure and the role of liver transplantation in that. So to take us through, we have two senior faculties. Dr. Devaprasad, who is a lead consultant in Apollo Hospital, Chennai, and Dr. Shiva Kumar Reddy, who is a director and senior consultant in critical care medicine at AIG Hospital, Gachibowli. So I welcome you both. So to take us through, we have our two students, Dr. Afan Ali Khan and Dr. Sandeep Pasupula. Both are IDCCM students. They will present a case, and I'll request you, examiner, at any point of time, if you feel you can interrupt and you can ask the questions and start the discussion. So I'll ask both of our students to start the case.
Thanks, Dr. Durgesh and the hospital for having us here. We'll go to the case.
Thank you.
Thank you, Dr. Durgesh.
Yeah.
Thank you.
Good evening to the respected faculty. With your permission, we'll begin the presentation, sir.
Please start.
Yes.
Please start.
Sir, my case was a 50-year-old male patient.
And the sound should be slightly more audible.
Okay, sir. My patient was a 50-year-old male with complaints of fever since 7 days, generalized weakness since 7 days, yellowish discoloration of the eyes since 5 days, and altered mental status since 1 day. Moving on to the history of presenting illness. The patient was apparently all right 7 days back, after which he developed a high-grade fever, which was on and off, which was not associated with chills, and it was relieved on taking medications. There was a history of jaundice since 5 days to the patient, which was associated with yellowish discoloration of the eyes, and the yellowish discoloration of the urine was also present. There was a history of altered sensorium, which had developed acutely since 1 day. There was no history of any vomiting or loose stools. There was no history of any hematemesis or melena. In the past history, there were no similar episodes in the past. There was no history of any hypertension, CAD. Our patient was a known case of diabetes. Under the personal history, the patient's diet was mixed, mainly based on the addictions. The patient was an alcoholic. He used to take country liquor about 90 ml per day since the past few years. The bowel and bladder habits were completely normal, and the appetite was decreased since the past 7 days.
Dr. Vishnu, Dr. Sandeep, just go back to the previous slide. Before the before the history is completely completed, maybe can you just briefly tell what could be the possible differential diagnosis based on the presentation which you have said?
Yes, sir. Sir, a patient who has presented to us with fever, altered mental status, and jaundice. The possible differentials in my mind would be a patient who has landed up in acute liver failure due to various causes. It can be a patient of chronic liver disease which has decompensated. It could be any case where the patient had sepsis, and this sepsis had led to fever, and then hypotension has led to that altered mental status. And then on top of that, there can be cholestatic jaundice due to the sepsis component, which can land up into this complication. Apart from that, in septic shock, the patient can have shock liver or ischemic hepatitis also can be there. And apart from that, acute cholangitis can also be one of the differentials. And tropical fevers like leptospirosis, dengue, malaria, and any hematological causes such as HLH can present like this. Any malignancies, sir, any leukemias, lymphomas, which has penetrated to the liver with the liver metastasis can also have a similar presentation, sir.
Okay. Just going through whatever you said, the first thing that you said was CLD decompensated to acute liver failure.
Yes, sir.
Can you call that acute liver failure? If a patient has got background CLD,
no, sir.
And then, so you can't say CLD decompensated.
Acute or chronic liver failure.
So that's a different entity. You can't call it acute liver failure. Sepsis, you said sepsis, septic encephalopathy also. Have you seen so many patients of septic shock presenting with shock liver? Do you think it's so common?
Ischemic hepatitis can occur.
Yeah, it can occur, but is it associated with septic shock? I understand that
Uh,
ischemic hepatitis is associated with shock, but there are various types of shock. Is it common to see it in septic shock? Have you? I mean, I'm just
uh,
asking you.
Rare,
Is,
sir, but it can happen. Rare.
which type of shock is it very common to see it?
Hypovolemic shock or hemorrhagic shock.
Hypovolemic shock, yes. Even more common?
Um, Sir, in cardiogenic shock due to
Yeah,
congestive
sure.
liver failure.
Yes. Most commonly in cardiogenic shock. Of course, it can be seen in hypovolemic shock, but of course. Acute cholangitis. Does your presentation fit in with acute cholangitis? What will be the presentation of acute cholangitis?
Sir, actually, it has fever, abdominal pain is more common in acute cholangitis, sir. And jaundice fever and abdominal pain is there in acute cholangitis, actually.
So there's no abdominal pain, and will there be any classical fever pattern?
Uh, in acute cholangitis, there will be low grade fever will be there, sir, in these patients.
Okay. Usually fever with rigors or okay, and abdominal pain will be there.
Yes.
Of course, tropical fever I can understand. And the last you said was hematological diseases.
Yes, sir.
Is it not?
Yes, sir.
Okay. Why do you think of hematological diseases?
Sir, any dengue patient, severe dengue with hepatitis, which has landed up into HLH, dengue related HLH, sometimes we can see that's why that came to my mind.
Dengue related HLH. Okay. 7 days of fever. Okay. Okay. You're very elaborate. In your first line, staying with your first slide, you stated it's 50-year-old male. Any significance of age and gender on acute liver failure?
Patients usually age less than 40 years present with Wilson's more commonly.
Okay.
Wilson's disease is more common in the young. So, and
Okay.
autoimmune hepatitis also, sir. It is more common in females in 30 to 50-year age group. And
Good.
yes,
What about pregnant females? What can they have acute
pregnant.
liver failure?
Yes, sir. Acute fatty liver of pregnancy can be there, or HELP syndrome can also be there.
So that's the importance of some gender as well. You
Yes.
stated the timeline so very elaborately here. Why have you stated it so? Is it just a part of your routine presentation, or is it something more that you've stated the timeline
Sir,
so very elaborately?
acute liver failure
You've
is
stated the
actually,
timelines very well.
yes.
You've stated them very well. Is there a particular reason to it, or you do it for all patients?
Sir, actually, in this patient, it will help us to prognosticate the disease, and also it will give us a clue to the etiology, because acute liver failure.
Prognosticate.
Sorry.
Prognosticate. It helps you to
Yes.
give etiology. Okay. How does
Yes.
it help you to prognosticate?
Sir, actually, patients with hyperacute and acute liver failure have a better prognosis when compared to patients with subacute liver failure.
Okay. So we'll talk about acute and subacute a little while later. And etiology, how does it help to determine the etiology?
Sir, usually hyperacute and acute liver failure cases are secondary to acetaminophen toxicity or any viral hepatitis. But when it is subacute, autoimmune hepatitis or Wilson's disease, something like that will come to my mind. But in a hyperacute case and an acute case, my most probable differentials that I will land up in the top list will be a viral hepatitis. Then it will be a case of acetaminophen toxicity.
Okay. Okay. Can you go to the next slide, please?
Yes, sir.
You talked about his no hematemesis and melena. So why did you say this?
Actually, if any patient with chronic liver disease is there, sir, then this history becomes more significant. And in a patient with acute liver failure, usually the definition says that there should be no history of cirrhosis or chronic liver disease.
Very good. So that's why. So now you understand when you first said CLD decompensated acute liver failure, why that's not a right statement to make. Yes. So you'll have to look and exclude stigmata of chronic liver disease. So, and you seem to suggest that hematemesis and melena not being present rules out the stigmata of previous liver disease.
Yes.
Okay. Okay. This patient had 1 dose of paracetamol, is it? A 650
So he was
milligram.
intermittently
You
taking
was
paracetamol since the past 7 days.
Okay. Next slide, please.
Yes, sir.
You said there's no history of diabetes, hypertension, CAD, asthma, and TB. Anything particularly that you want to convey in this past history?
Sir, in a patient who has in a past history of TB, if he is in
Yes.
active TB or something, then anti-tubercular drugs are one of the most common causes of acute liver failure in India.
Okay. So, which is the most hepatotoxic drug among the agents that we use?
Ethambutol, isoniazid,
Make up your mind.
pyrazinamide. Sorry, sir, pyrazinamide. Yes.
Okay, pyrazinamide hepatotoxics. After that?
It is rifampicin, then isoniazid.
Okay, so in a patient with acute liver failure on any of these ATTs, what would you do?
Sir, we'll ideally stop all the hepatotoxic drugs. Then we reinitiate each and every drug. And then after initiating the drug, we will repeat the LFT. And we will see if the LFT is worsening after the introduction of this drug. If it is not, then it means that this was the drug which is not responsible. Then I will introduce the second drug. Then I will see the LFT trend. Then with that, I will come to a conclusion, sir, which was the hepatotoxic drug. And I will replace that with a second line drug.
Okay, so this will be your strategy, is it? I'm going to ask you this again. You said the word ideally I'll stop all drugs. So if someone says no, stop each drug individually, what is your answer to it?
I'll start isoniazid first, sir, in this patient, and the least likely.
No, I'm not asking you how you treat a patient with ATT-induced hepatitis. We are talking about. I really don't know. We have not gotten into the different these
Yes,
cases,
yes.
but you seem to suggest that what you're dealing with is a patient with acute liver failure, which means we are talking about certain aspects which is different from an ATT-induced hepatitis. So ATT-induced hepatitis and acute liver failure because of uh, ATT, is slightly different entity.
Yes,
In this,
yes.
will you still take time to stop each of the drugs individually, or you'll stop all of them at once? Because the other strategy, stopping each of them, also is a strategy that is that is really taken care of by some people. But in this situation, when you're talking about an acute liver failure precipitated by possible tuberculosis drugs, what would you do?
Sir, ideally, I will stop all the drugs because here the treatment of.
And you said you'll reintroduce those drugs. Would you do that?
No, sir. Actually, in this case, we should not because acute liver failure carries a high mortality. So my priority is to save the patient, then treat the TB later.
Then yes, then you will probably start on liver sparing ATT. Of course, don't catch me wrong. If this is an ATT-induced hepatitis with the liver failure that is not fitting into the category of acute liver failure, then you may either stop all drugs or you may stop each drug individually and then reintroduce. But I'm just trying to get the point through that if it is an acute liver failure due to tuberculosis drugs, then you will probably deal it differently. And you elaborated a bit on the personal history in greater detail. You said he's taking country liquor about 90 ml per day. Do you think this can be methanol poisoning?
Sir, methanol poisoning is usually associated with the severe lactic acidosis. Is there, sir, in these patients? And
did your patient have lactic acidosis?
yes, sir. Patient did have lactic.
Okay, so he has that then.
Delirium is there, sir, in these patients. Usually drowsy.
Okay.
Patients are drowsy.
Okay, so was he drowsy?
Yes, sir.
Okay, then.
From that, any features of cirrhosis or anything like that, sir?
Cirrhosis.
Cirrhosis and long-term usage of alcohol.
Oh, okay. So anything with the pupils?
Methanol, sir, it is usually.
Okay, let me not put you into it. I want you to probably come back and tell us about how will you rule in or rule out in a methanol poisoning, but I'm not even saying this. Okay, then. So you were until this slide, no? You are until this slide.
Yes, a couple of things, sir. I just want to ask any other negative history you would want to ask here. I mean, there's an acute febrile illness, probably having some sort of liver dysfunction with looking at probably some altered sensorium as well. In such a scenario, any other negative history you would want to ask?
Sir, if there is any history of travel,
okay,
to rule out any.
Why do you want to ask history of travel?
Sir, any malaria endemic areas and malaria, dengue like that.
Okay.
And if there is any history of binge alcohol intake in these
Okay.
patients.
Outside food intake.
Outside food intake for
Okay.
viral
Why,
hepatitis.
why are you asking outside food intake?
Hepatitis,
Hepatitis.
viral hepatitis.
Okay.
Hepatitis A and
A
E.
and E.
Okay. And
And acute gastroenteritis and with hepatitis A and E with outside food consumption.
okay. So fairly good enough. I think probably that is the negative history. Definitely, I would want to rule out history of travel, history of and anything related to the diet. Probably something.
Mushroom poison.
Mushroom poisoning here. There's nothing related to fever. Usually, it doesn't. So you want to ask anything, sir?
No, I think we can, if you have nothing, we can
Yes.
probably proceed.
Yes. Please go next.
Yes. So under general examination, my patient was moderately built and well nourished. There was no pallor, cyanosis, clubbing, lymphadenopathy. The positive points were the patient had icterus and pedal edema was present in my patient. On examination, the patient was drowsy and arousable. The heart rate was about 102 beats per minute. The blood pressure was 100 by 50 mmHg. The patient was on noradrenaline at 0.5 microgram per kg per minute, along with vasopressin at 0.03 units per minute. The SpO2 was, the patient was intubated on invasive mechanical ventilatory support with a saturation of 95%. His RR was 28, his GRBS was around 86 milligram per deciliter. Under systemic examination, the inspection of the abdomen, the abdomen was mildly distended, the umbilicus was inverted, there was no localized swelling, discoloration, or any pulsations. There was no visible peristalsis, scars, or sinuses. There was no dilated superficial veins, and there were no stigmata for chronic liver disease. CVS S1 S2 was heard. Apical impulse was at the fourth intercostal space, and there was no murmur. On the respiratory system examination, there was bilateral crepitations. Under the neurological examination, the patient was drowsy but arousable. The pupils were 2 mm, reactive to light bilaterally. The patient was intubated, so the GCS was E2, VT, and M4.
Can you go back to the first slide of, the examination? Yeah, the general examination, yeah. So you have mentioned that this patient is having a pedal edema.
Yes, sir.
What does pedal edema in this case suggest? You're
Sir,
thinking of an acute febrile illness who was having a non-cardiac, he didn't have any cardiac related issues. And probably, what does it suggest?
Sir, in my case, actually the patient had bilateral crepitations and pedal edema. The patient actually had myocarditis related picture, sir. So that is why he had pedal edema. But if I take it out of context to this patient, sir, pedal edema can be seen due to any hypoalbuminemia or anything, sir.
Okay. So looks like your patient was hemodynamically unstable.
Yes.
At the time this thing. This is like you have received this patient. Already patient is in the ICU.
Yes. Yes. Exactly.
So can you just tell what is the current status right now? Maybe summarize based on the examination findings which you have said.
So the current status is that the patient was hemodynamically unstable on dual vasopressor support. The patient was intubated with and was on invasive mechanical ventilatory support. And the patient was drowsy, arousable with the GCS of around E2, VT, and M4. And the patient came to us in a state of hypoglycemia with tachypnea.
Okay. This patient, as I can see, is intubated, right?
Yes.
What is the reason for intubation?
Sir, actually, the patient had a cardiac arrest in the outside hospital, due to which he was status post CPR, sir, this patient. So after CPR, during CPR, they had intubated, and the patient was shifted to us in an ambulance with the dual vasopressor support and already with the tube in situ.
So she was shifted from elsewhere in an intubated state. Okay.
Yes.
if this patient was a patient who's presented to you in your hospital, in your emergency or shifted from the wards, what would be the reasons for intubating these patients with acute liver failure? This is what you're discussing today.
Yes, yes.
Yes.
So, yes.
Encephalopathy grade 3 to 4, we have to intubate the patient, sir,
So why do you want to do that?
to prevent aspiration. And
Okay.
Cerebral edema, the risk is very high, sir. When the patient is not intubated and agitated, and if the patient is not sedated deeply, any agitated behavior of this patient can rise the ICP, and this patient can suddenly cone, and cerebral herniation can happen. So we want to prevent this in this patients with grade 3 and grade 4 encephalopathy. That is why we intubate them, keep them deeply sedated.
Okay. So you're telling me that that's a treatment option, right? So if they are in acute liver failure with grade 3 or grade 4 encephalopathy, they would have acute cerebral edema. And one of the treatment options for acute cerebral edema is sedate this patient.
Yes.
Of course, aspiration will be prevented, but that's one good thing that of intubation. But the primary reason for intubation is as a treatment modality for an acute cerebral edema. That's what you're trying to tell me. Okay,
Yes.
that's fine. I mean, as Dr. Shiva has already asked, would you expect pedal edema in patients with acute liver failure?
No, sir.
Okay, you don't. In this particular patient, you said you thought it was because of hypoalbuminemia. That's okay. Myocarditis. You said this patient had myocarditis.
Yes.
Why did you say that he had myocarditis?
Actually, sir, further into the presentation, when we evaluated the patient was found out to be leptospira IgM positive. And
Okay.
his 2D echo was suggestive of global LV hypokinesia. His tropi and anti-proBNP were elevated in thousands. So that is why probably in this case, the patient had this pulmonary edema due to the heart failure component, which eventually landed up in pedal edema also.
One suggestion, Dr. Sandeep, the thing is, whenever we are discussing at this level, it has to be based on our examination findings. I think we
Sorry.
subsequently to the myocarditis or probably whether he was diagnosed to have a failure or leptospirosis. Right now,
Yes.
probably based on the history, what would be? Because the case is evolving. So as
Yes.
the case is evolving, we would like you to discuss based on that.
Yes. Yes, I'll keep it.
I think you understood what Dr. Shiva is saying.
Yes, sir.
See, now you have the benefit of knowing what happened to this particular patient. You have this information upfront with you.
Yes, sir. Yes.
In an exam, and of course, exam is a very small part of all our life. No, the real exam is every patient that you see. You will not have all this information upfront when you're seeing this patient. So we are just trying to understand from you, if you have only this information and this findings for this particular patient at this point of time, what will be your thought process?
Sir, a patient with fever, jaundice, and altered mental status, I would probably, based on my workup, I would think about tropical fevers also, sir. So because of the tropical fever related, the myocarditis will be the coming onto this thing, sir. Any dengue related viral myocarditis can be there if there is in this patient.
Okay. Okay, then. So this patient, I think what you could have also said in the history was this patient was received in a post CPR status. So can the post CPR itself explain the myocardial dysfunction?
Yes, sir, it can.
Okay. Okay, then.
Next slide, please.
Yes.
Don't think anything. Sir, you want to ask anything in this one, sir?
No, nothing there. Next, nothing, please.
Okay, here you felt that the patient was a bit drowsy. Patient was having low GCS. With your background history, now that you have evaluated him in certain things, anything else you would want to add in the neurological examination?
Babinski's reflex. Because the altered.
So you want to check the reflexive?
Yes. Babinski sign, if it is positive in the background of an altered mental status, it can indicate any stroke or intracerebral hemorrhage also, sir. So we need to check the Babinski sign if it is equivocal or if it is upgoing.
Okay. Any focal neurological deficits also have to be ruled out. Yes.
Yes.
Okay. Fairly good enough. Shall we go for the provisional diagnosis, sir?
Yeah, please.
Yes.
Please.
So the provisional diagnosis for my patient would be septic shock with acute liver failure with grade 3 hepatic encephalopathy, with the probable etiologies being viral hepatitis, tropical fever, ischemic hepatitis, drug-induced liver failure, alcoholic hepatitis, or acute cholecystitis.
Oh,
Wow, great list there. Okay, let me ask you, define septic shock, please.
Sir, a map of less than 65 mmHg despite fluid resuscitation is referred to as septic shock.
Is that all?
Associated
First-
with vasopressor support.
Okay, is that all?
In the background of an infection, sir, leukocytosis.
Okay, so in a patient with infection, if he has shock and the shock it persists despite adequate fluid resuscitation, patient needing vasopressors, and the map is still 65 plus anything else? Any lab, any?
with elevated lactate levels.
Okay.
No,
Lactate
Okay.
levels more than
about
4 million.
any organ function or anything?
With uh,
So with elevated lactate, you said that.
yes.
Okay. Acute liver failure. Can you define acute liver failure for me?
Yes, sir. Acute liver failure is defined as severe acute liver injury as characterized by jaundice or hepatitis, along with coagulopathy with an INR of more than 1.5 and hepatic encephalopathy, which occurs in less than 26 weeks. In the absence of a background cirrhosis or a chronic liver disease, is termed as acute liver failure.
So patient should have a hepatic encephalopathy plus coagulopathy as defined as an INR of more than 1.5.
Yes.
And it should have features of acute liver dysfunction. The whole timeline is 26 weeks.
Yes.
And you should not have stigmata of cirrhosis or chronic liver
Cirrhosis.
disease. So that's what you said. So I think so when you make these diagnoses, that's exactly why your timeline was very important, no? Your
Yes,
timeline to say that all of this happened within 26 weeks, that this particular patient had hepatic encephalopathy and coagulopathy, and he had no stigmata of
Liver disease.
evidence of chronic liver disease. That's fine. And you said this patient has got grade 3 hepatic encephalopathy. Can you tell me the definition of hepatic encephalopathy? How do you assess them? How do you grade them?
Sir, an altered mental status secondary to hyperammonemia will be defined as hepatic encephalopathy. I would grade hepatic
Sorry.
Yes.
Sorry to interrupt. I'll just note down what you said. What did you say, please?
Sir, altered mental status secondary to hyperammonemia is defined as hepatic encephalopathy. And we would grade hepatic encephalopathy based on the West Haven grading, sir. On the
Based on the
West Haven grading, sir.
Okay, West Haven grading. Okay.
Sir, with the grade 1 being altered sleep cycle, in which asterisks may or may not be present. Grade 2, the patient is confused with the asterisks is present in this patient. In the grade 3, the patient is drowsy but arousable and disoriented to time and place. And asterisks is again present in this case. And in grade 4, the patient is comatose and asterisks is not seen in this grade 4 hepatic encephalopathy.
Okay. Since you said so much about asterisks, in your clinical examination, did you look for asterisks? When they asked you what else you look for, you said, I look for tone, and you also said you look for Babinski's. And of course, Dr. Shiva told me that you'll have to look for any focal deficits,
Yes.
which is
And
very important. So did you look for asterisks?
At that time, asterisks, yes.
So you did. How do you look for asterisks in these patients? He's only got M4.
Yes, sir. Sir, asterixis can also be demonstrated by hip flexion also, sir. There will be outward movement of the legs in this patient. Because the patient is not conscious enough to extend his hands in front of his body. What we can do is we can flex the legs and look for hips moving apart. So this can also be defined as asterixis.
Or hyperextend the foot.
Oh, yes, yes.
Okay, that's one way. Okay, that you said that was there. And you said something very interesting. To say that it is hepatic encephalopathy, you should have an altered mental status secondary to hyperammonemia. So are you trying to tell me that I have to send a serum ammonium level and I have to show that the serum ammonium level is elevated and only then call it hepatic encephalopathy? Is that so essential to the diagnosis?
Yes, actually, elevated ammonia levels of more than 50 is usually needed for hepatic encephalopathy.
So if you don't have an elevated ammonia, you don't call it hepatic encephalopathy in a setting of acute liver failure.
We can cause other causes.
No, I'm just asking you the question. Is just like how we have septic shock, we said so much of MAP, so much of fluid resuscitation, need for inotropes, lactate, all of it defines it. I'm asking you, is a measurement and demonstration of an elevated hyperammonemia central to a diagnosis of hepatic encephalopathy in a patient with acute liver failure?
A baseline absolute rise of ammonia is usually needed, sir.
So demonstration is needed. So you would stick to the fact that I should have a raise in serum ammonia to call it hepatic encephalopathy, right?
Yes.
Okay, we'll come to that at the end. Okay, and you've listed a list of diagnoses: viral hepatitis, okay, tropical fevers. You did talk about tropical fevers, ischemic hepatitis. You did said drug-induced liver failure, paracetamol. What doses of paracetamol are typically associated with the acute liver failure?
Actually, more than 8 grams per day, sir, is associated with acute liver failure.
Six also 6 to 8 grams. Okay. Any you said TB drugs can also cause drug-induced hepatitis. Any other drugs?
Sir, amiodarone can also cause. Any anti-epileptic drugs can cause, sir, such as valproate, phenytoin. Actually, in India, herbal medications, alternative medications are very common cause of drug-induced liver injury in India. Apart from that, any paracetamol, this.
So I don't know whether valproate in the regular doses it will cause that way. Valproate will usually, if you have a use, it may cause hepatitis or it may cause Steven Johnson syndrome or TN where the liver may be involved. So
Yes.
maybe drug overdose of any of these hepatotoxic drugs can cause it. Yes, alcoholic hepatitis, yes. Acute cholecystitis, will that cause acute liver failure and hepatic encephalopathy? Do you want to still put it there?
No, sir, because history of abdominal pain is not there, so likely to be
Sure.
acute
Let's
cholecystitis.
let's say the patient has got abdominal pain. Let's say, do you think acute cholecystitis will cause acute liver failure?
Unlikely.
Okay, Dr. Shiva, anything that you would want to ask?
If this patient had an abdominal pain, any other cause which can actually lead to some sort of a acute liver failure sort of situation? Any other severe abdominal pain, somebody who's had.
Sir, alcoholic hepatitis in the background of a binge drinking, usually they present with severe abdominal pain, but that is more related to acute or chronic liver failure.
So somebody who's had a binge of alcohol develops some abdominal pain, some other probably his
Any other
contribution of something else. So something which is there in the biliary tract can cause.
Primary biliary cholangitis.
No. Anything related to okay, something which is abdominal pain, pain radiating to the back, caused by
Pancreatitis.
Yes, pancreatitis. But what sort of pancreatitis can cause?
Necrotizing?
No, maybe in the last stages. But the same thing, the same history which you have suggested.
The calculus,
Yes, biliary
calculus,
pancreatitis.
the cause of the acute pancreatitis being calculus, this can present with acute cholecystitis along with the patient with acute pancreatitis. These patients.
Yes, I think that is what sir was suggesting.
Yes, yes, yes.
Okay. Staying with that particular case, if someone has abdominal pain and presents with acute liver failure and it's not pancreatitis or biliary cause of it, what else will you suspect? Of course, ischemic hepatitis can present with a lot of pain. Yeah. Anything else?
Liver abscess, sir. Any liver abscess or congestive cardiac failure related tender hepatomegaly can also be there.
That's what we said. Yes, yes. Can you just say one any other cause where the liver becomes big?
Hepatocellular
Yes.
carcinoma.
Hepatocellular carcinoma, okay. But acutely, yeah, of course. All these present over a period of time, definitely. Acute, maybe related to pregnancy, sometimes maybe related
Acute fatty
to.
liver of pregnancy.
Okay, good. Anything, liver is enlarged and there is an outflow tract obstruction.
Buchiari syndrome.
Yes.
Yeah, acute Buchiari. So that's something that you will have to keep in your
Yes.
mind. So if someone presents with acute liver failure and has got abdominal pain, so what are the things? Yes, you said AFLP is a possibility. Ischemic hepatitis with massive uh, possible, but generally you'll have to look at a stretching of the capsule in these patients, like Buchiari and hepatic venous outflow tract obstruction. Of course, pancreatitis was also mentioned. So these are some of the differential diagnoses that you should probably keep when you are.
Yes.
Okay.
Shall I move to the next slide?
Yes, please.
Yeah,
If Dr.
please.
Shiva has finished, is it okay?
Yes, sir.
Yes, please.
Sir, so the outside investigations for these patients, before moving on, the patient had a raised.
So, okay, before we actually do these investigations, based on your provisional history, I mean, what investigations you would want to do? Imagine this patient, basically go back to your provisional diagnosis. Based on your provisional diagnosis, what sort of investigations you would want to investigate in this patient?
Sir, firstly, I would like to send a CBC, LFT, a PTINR, and an ammonia level. Then, based on the LFT report, based on the bilirubin, based on the SGOT, PT levels, and how they are correlating, based on that, I would like to evaluate the patient further. For example, if the patient has OTPT levels which are in thousands, then I would mostly think in terms of viral hepatitis. So my workup will go in favor of anti-HAV IgM and anti-HEV IgM. And any drugs I will evaluate for acetaminophen levels also. But if they're morely likely in range of 300 to 100, my thinking will be in terms of alcoholic hepatitis. And if SGOT is more than, usually in these cases, PT is more than OT, sir. But a reversal of OTPT, that is OT being more than PT, will make me think about certain diseases such as ischemic hepatitis, alcoholic hepatitis, or even Wilson's can present with an OTPT reversal. Then I would like to look at the bilirubin levels. That will also give me a clue. A direct elevated direct bilirubin, which is much more disproportionate, will land up to a thinking of about deep jaundice, leptospirosis kind of a picture will be there. And based on this, I would like to also evaluate for the creatinine levels and do an ABG also in the patient, and a PTINR and an ammonia, which will help me prognosticate the case on a further basis.
You'd want to rule out the other causes, something you just have suggested only ALF, example for ALF, but you want to do some investigations to rule out other things, right?
Yes, sir. HBsAg, HIV, and HCV also, triple H viral screening should be also have to do, sir. And then based on the history,
Tropical
workup also, sir.
Okay.
Okay. Would you do an ultrasound?
Yes, sir.
Will that also be a workup?
Yes, sir.
Okay, just to get into perspective. So when you work up for any patient, this is an acute liver failure. So you do investigations to confirm the diagnosis. You do investigations to identify the etiology of the diagnosis, and you do some investigations to find out some of the complications that are likely to be associated with this particular diagnosis. So if you can put it into these categories, I think you will not miss things out. I mean, I think you've been an elaborate answer. I'm not even saying no, but I still think that you've probably left out a few investigations that you may have otherwise said. For example, an ultrasound would be key to it.
Yes.
Yes.
Would be key. So, so I just want you to just for not only for this patient, any patient, what is my provisional diagnosis? So what do I do to confirm my provisional diagnosis? Okay, this is the etiology that I'm saying. What will be the etiology? What are the complications I expect? And what are the things that I have to do to rule out other differential diagnoses that can also coexist? So this will help you to really
Yes.
not miss out anything. Okay.
Yes.
Yeah, please, you can go to the next slide, please.
Yes. So the outside investigations which we received in the patient, going through the significant findings, the patient landed up in leukocytosis with thrombocytopenia, raised creatinine level with raised INR, OT, PT was elevated more than 100 times, ammonia was around 80, and the USG abdomen was already done outside, which suggested grade 2 fatty liver, and the kidneys, the CMD were maintained. The dengue and S1, they had sensor, which came negative. Sir,
Okay, so first page, I mean, that slide alone, previous slide alone.
yes, sir.
Okay. What do you make up of the increased total count?
Sir, it is leukocytosis, any sepsis infection is there, underlying infection.
Okay. So your provisional diagnosis said septic shock.
Yes,
So
sir.
I just want to again highlight the fact. Did you send out any blood cultures in your
Yes, sir.
when Dr. Shiva asked what investigations you want to do? Did you mention blood cultures?
No, sir, no, sir. That was.
No. I mean, I'm just trying to highlight to you certain aspects that we would want. So if you go back to your previous slide, provisional.
Yes.
So you started with septic shock. Okay. So I'm just trying to let you know that if these are the, but at the same time, don't uh, keep your differential diagnosis list, everything that you read in up to date or whatever it is. No, otherwise the amount of investigation that you're going to order in your patient is going to be so massive, and some of them will be redundant also. So just let's be rational in our investigations as well. Okay, coming back to the next slide, please. What is the significance of the raised creatinine and urea and creatinine in this patient?
Sir, these patients usually due to hypertension have a pre-renal AKI. A bun-creat ratio will be important. Bun-creat ratio more than 20:1, as in this case, will indicate that I'm dealing with a pre-renal AKI. Or in this case, there can be any sepsis-related acute 18 also, sir. Or in a case of acute liver failure, we can be dealing with hepatorenal syndrome, but more common with cirrhosis-related patients.
Can acute liver failure cause hepatorenal syndrome?
No, sir.
No, sir. Cirrhosis is the criteria to diagnose HRS. Sorry.
Okay. PT INR is elevated. Okay. You expect that with liver failure, you said. SGOT, SGPT is more than thousands. And you said if it's more than thousands, you think of viral hepatitis, you think of toxin related hepatitis. Is there any other thing that will tell you that it is usually more than thousands?
Ischemic hepatitis.
Ischemic hepatitis also is more than thousands.
So how do you
Okay.
differentiate? Usually what happens, how do you differentiate between the OTPTs of viral hepatitis versus the ischemic ones?
Sir, in viral hepatitis, PT is more than OT in most of the cases, and it is in thousands. But in ischemic hepatitis is one of the conditions in which the OT-PT is in thousands, but OT is more than PT in a case of ischemic hepatitis.
Okay, fine. Yeah, thank you.
Yes.
Yeah, next.
Yes. Sir, on day 1, on arrival to the ER, so the patient was received to ER in an ambulance. The patient was status for CPR at outside hospital. We received the patient with mechanical ventilatory support and on noradrenaline and vasopressor supports as mentioned. The urine output of the patient was around 30 to 35 ml per hour. We had done a POCUS on arrival for the patient. It was suggestive of global hypokinesia of the left ventricle, bilateral B profiling. The IVC distensibility index was checked. It was 2.2 centimeters and less than 50% collapsing. No evidence of any pleural effusion. An ONSD was done, which was 0.67 on the right and 0.64 on the left. The plan of care for this patient, based upon the evidence of thrombocytopenia along with the background history of fever, we had sent a tropical fever from the baseline, and blood, urine, and ET culture was already sent before the starting the empirical antibiotic therapy. As the patient, we started with penem and doxycycline, high-grade antibiotics, because the patient was already in septic shock. We, because the OTPT were elevated, we started the patient on 3%. We started the patient on NAC infusion, and as the patient was in grade 3 hepatic encephalopathy with a low GCS, suspecting cerebral edema with an ONSD which was elevated, we started the patient on 3% NaCl infusion also. And because the patient had the global LV hypokinesia on the background of thrombocytopenia and fever, we sent NT-proBNP and TROPI, and we, yes. And on the day one, the significant investigations were the TLC count was worsening, the platelet counts at our hospital were worsening. The creatinine has increased to 2.1. The INR had increased to 2.1. The OTPT was worsening when compared to the outside investigation report. The bilirubin, the direct bilirubin and the indirect both were elevated. The ammonia was elevated and the sodium was on the lower side. It was 128. We did an ABG on arrival for the patient. The ABG was suggestive of severe metabolic acidosis with respiratory alkalosis as a compensation, and high anion gap metabolic acidosis with elevated lactates, probably lactic acidosis.
You said the patient also had respiratory alkalosis, no? So why did you say that?
Sir, because of the metabolic acidosis component, there can be acidotic breathing in this patient, which leads to secondary.
No, I'm just asking you.
Yes.
And just use the ABJ and tell me why you said there is also a respiratory alkalosis. How do you say that?
Normal PCO2 levels are 40, sir. In this patient, the PCO2 levels are 25. This indicates that the patient has a respiratory has an alkalosis component, respiratory alkalosis component.
Do you have a formula to calculate these PCO2?
Yes, sir. The Winters formula is there, sir, in which
can you tell me the Winters formula, please?
Yes, sir. It is 1.5 into 24 minus bicarbonate plus 8 plus or minus 2.
Okay, can you use this formula and tell me what's the PCO2?
Yes, sir. So 24, 14. The PCO2 levels come around 20, 22, 23, sir. Plus or minus 2 is 25. So it indicates a compensated respiratory alkalosis in this ABG.
So I'm not sure whether there's a respiratory alkalosis component. It's just
Metabolic
what metabolic acidosis that you have. And of course, I agree with the diagnosis, high anion gap. So what is the cause of high anion gap metabolic acidosis?
Lactic acidosis.
Lactic acidosis, okay. Then?
Uremic acidosis, lactic acidosis can be there, or any diabetic ketoacidosis, any methanol poisoning, ethanol poisoning can also cause lactic acidosis. Sometimes metformin drug toxicity is associated with lactic acidosis. Linezolid drug toxicity is associated with lactic acidosis.
Okay, so this patient has got lactic acidosis as well as renal failure. So both of it could have contributed to the high anion gap metabolic acidosis.
Yes.
Okay then. What is the significance of hyponatremia in a patient with acute liver failure?
Sir, hyponatremia is actually related to worsening mortality in patients with acute liver failure. A fall in the sodium is correlated with cerebral edema in these patients, sir. It helps as a prognostic marker also in the MELD sodium score. 3-month mortality rate is also predicted with the MELD sodium score, where sodium plays a very important role.
Okay. In this slide that you have put up for us, there are certain things that are very imperative on the prognosis. One you said is the sodium. anything else that you can identify and tell us that it will help to?
So the INR levels and the bilirubin levels strongly correlate with the prognosis in a patient with acute liver failure. Because the synthetic function of the liver is mainly producing the bilirubin and is mainly producing the clotting factors and clearing the bilirubin. Hence, when the liver is damaged and the synthetic function of the liver is damaged, raised INR and raised bilirubin levels indicate a poor prognostication in a case of acute liver failure.
Okay. Is the rise in creatinine also important?
Yes, sir. Middle school.
Yes, sir.
Does an elevated lactate also help?
Sir, lactate elevation is also a poor prognostic marker in a case of acute liver failure. But the thing is, this lactate is cleared by the liver, by the Cori's cycle. So in these patients, due to the hypoperfusion, there is elevated lactate production. And due to the dysfunction of the liver, there is an elevated decreased clearance of the lactate. So the lactate in these cases are mainly used as a prognostic marker for acute liver failure, but we cannot use it as a index for resuscitation, for fluid resuscitation.
So, no, I just asked you, what are in this slide, what investigations that you have used are used for prognosticating or used for making other therapeutic decisions? You've said most of them here. Of course, sugars will also important. No? Hypoglycemia, though it doesn't come in any of the criteria, hypoglycemia, persistent, profound hypoglycemia is an important marker of prognosis also. Okay, next. I mean, if Dr. Shiva has anything more to ask in this particular slide.
So, I mean, you have evaluated this patient as possible acute liver failure at the time of your admission itself. So, I mean, what would be your choice of empirical antibiotics? I mean, why specifically meropenem? Why doxycycline?
Sir, given the background history of fever and thrombocytopenia, my thinking would go in terms of tropical fever. And
Okay.
tropical fevers, to cover the tropical fevers, atypical cover is required. So
Yes.
I would add doxycycline or azithromycin in this case. That is this thing. And I have added meropenem in this case because the patient is already in septic shock on invasive ventilatory support. So it would be an anti-pseudomonal as well as an anti-pneumococcal cover. And because in acute liver failure, the chances of infection are very high because of neutrophil dysfunction.
So yes, as you rightly said, I think antibiotic is very, very important, especially in a patient with ALF. So you've also started NAC and 3% NaCl. I mean, why did you start 3% NaCl upfront? And was there any reason behind that? And why did you start NAC?
Sir, 3% NaCl in my case landed up already in grade 3 hepatic encephalopathy. My patient was drowsy and arousable. This was the first point for me starting 3% NaCl in my case. The next point would be that the patient's ONSD, which we had screened, indicated that there was cerebral edema. A normal ONSD is less than 0.56, and ONSD of optic nerve sheath diameter of more than 0.56 indicates that the intracerebral pressure is more than 20 mmHg. So in my case, both of this indicated that the patient was already in cerebral edema. So that is why I would wanted to start the patient on 3% NaCl. And the choice also dependent because the patient had AKI. So I can't start mannitol, so I preferred.
Yes.
The target should be around 145 to 157.
Okay. So your sodium was around 128, so you have considered 3% saline.
Yes.
Okay, you have started NAC infusion also. Why you have started and what dose you have started?
Yes, sir. As OTPT levels were elevated, there is evidence of NAC being helpful in patients with non-paracetamol related acute liver failure. And the dose that we started was IV 21-hour protocol of NAC infusion was started. We gave 150 mg per kg over 1 hour in 250 ml D5. Then we went on to 50 mg per kg in 4 hours in 500 ml of D5. Then we went on to 100 mg per kg of over 16 hours in 1000 ml of D5. So,
what you're describing seems to me a protocol that is used for
paracetamol.
Yes. Is it been extrapolated and found to be useful in other cases of liver failure also? That's
So,
probably the question that Dr. Shiva is trying to ask.
so there was a trial which was published in NAGM 2009, which I went through, in which there was evidence of NAC being helpful to improve the transplant-free survival rates in patients with acute liver failure, but it indicated and limited to only grade 1 and grade 2 hepatic encephalopathy. It didn't extend to grade 3 and grade 4 hepatic encephalopathy. But in my case, NAC was started even grade 3 because NAC as such does not have any significant side effects. So no potential harm.
I mean, this was a patient probably who was having a significant LV dysfunction. Already, I think probably you would want to consider giving so much volumes of NAC.
Yes, sir. Yes. Already fluid overload.
So that's also one more thing, which is a very significant thing.
Yes.
And anything else you would want to add in this? I mean, which is very important for me. You have started this patient on mechanical ventilation, NORAD, vasopressin, dual pressors. You've started antibiotics. Something main thing.
Sedation.
Yeah.
Sodium is low, 128.
Tolvaptan.
No.
Hydrocort, sir. Hydrocort.
Yes.
Yes. Hydrocortisone 50 mg IV QID has been in septic shock patients. It is very important.
Is it only in septic shock patients?
Yes. Usually when the dosing goes beyond 0.5 microgram per kg per minute, it is evidence of adding hydrocort in these patients. Gives evidence that there is a resolution of shock earlier when compared to patients which are not on hydrocort.
Okay, fine. I mean, I would. It's not only sepsis. I think. I mean, chat box is actually coming up with answers. Lot of answers. So I think CIRSE, adrenal, relative adrenal insufficiency. A lot of indications are there.
Yes.
Oh, and probably ALF usually tends to have some sort of a hypoadrenergic state. So insufficiency would be there. So definitely we should have considered steroids in that. Yeah.
Yes.
And the relative hypoadrenal state is one of the reasons that is also implicated in the etiology of low sodiums in these patients.
Yes. Can I move to the next slide?
Yeah, next slide.
So the lab reports which were sent came out as Leptospira IgM came out as positive, Plasmodium falciparum and Vivax peripheral smear came out as negative. We had repeated dengue IgM and an IgE which came out negative. Triple H came out negative. The cultures were still awaited. We did an official 2D echo. The EF was 35% with global LV hypokinesia. The TROPI came to be around 950 and NT-proBNP came to be around 15,000 in my case.
So leptospirosis IgM is positive. So do you think this is leptospirosis induced acute liver failure?
Sir, it is actually with the OTPT being in thousands, it is unlikely that it is leptospira related because in leptospira, the OTPT are usually elevated between 200 to 900 more likely. And
even lesser. Even lesser than that. Yes, agreed.
Yes, and even my so my thinking would go more in terms of ischemic hepatitis because of during CPR there will be hypotension because of that shock liver, and it goes more in terms of ischemic hepatitis rather than leptospirosis in this case.
Okay.
Or maybe it might have been a bystander, possibly.
Yes.
Bystander effect must have been there. That's all.
Yes. So this was the medication chart which was started on day 1. meropenem 500 mg IV TID and doxy 100 mg IV BD with the antibiotic cover that we gave. We had started the patient on NAC infusion for 21 hours and injection 3% NaCl infusion was also ongoing. And then we added hydrocort 50 mg IV QID. And because of recurrent episodes of hypoglycemia, we had to add an injection B50 infusion in this case. Apart from that, we had added human albumin and Lasix infusion. And to sedate, we used midazolam infusions.
Midazolam infusion. What do you think about midazolam infusion for sedating patients with acute liver failure?
Sir, actually, midazolam is not the perfect or the ideal choice because it is a long-acting agent. In my case, ideally, short-acting agents such as fentanyl would have been better.
Propofol.
Midazolam is long acting, is it?
Short-acting, sir, but more than duration is shorter only, but but maybe fentanyl would have been a better option.
Any other drug?
Propofol, sir.
The
Propofol.
patient is
Any
hemodynamically unstable.
hemodynamic instability, can that be a contraindication for propofol?
Yes, sir. It can lead to hypertension. Propofol can.
Any other agents?
Propofol infusion syndrome can also. Sir.
No, you're not giving the propofol only.
Remifentanil has been upcoming, sir.
Okay. Any role of ketamine in these patients?
So
Any
ketamine
worry?
will further
Any worry of using ketamine?
Yes, sir. Ketamine will further increase my blood pressure, the intracerebral perfusion. It will worsen my cerebral edema. So I would not prefer ketamine in this case.
Okay. You suppose this is a patient, you know that it's acute liver failure because of paracetamol poisoning. Okay. Any of the things that you will take off from your prescription? What are the things that will go off from your prescription?
Vitamin K can probably be omitted. Albumin can be omitted. Albumin and vitamin K can be omitted. So doxycycline, meropenem can also be omitted. Okay.
So what do you think about the role of prophylactic antibiotics in a patient with acute liver failure? Of course, this is you're thinking in terms of infection and infection also precipitating. That's a different. But otherwise, acute liver failure, non-infective etiologies. What do you think about the role of prophylactic antibiotics?
Sir, according to the EACA guidelines, they recommend that the prophylactic antibiotics are to be used in the patients with the warning signs such as any fever, leukocytosis, any grade 3 or grade 4 hepatic encephalopathy. They have recommended the use of prophylactic antibiotics to be helpful. Apart from that, if these indications are not there, they do not recommend to start the prophylactic antibiotics in this case. And any patient with long-term ICU stay, antifungals may be helpful is mentioned. Sir.
Do they recommend
anything else?
carbapenem? Did they recommend carbapenem?
No, sir. No, sir.
Then what did they recommend?
No, they recommended not to start, sir. Prophylactic antibiotics.
But even if you have to start, what did they say? I mean,
Empirical antibiotics.
Ceftriaxone, what they have mentioned.
Third
Ceftriaxone 1 gram BD they have mentioned. And cefotaxime as an alternative. They have not mentioned meropenem.
Okay. Is there any role of surveillance cultures in these patients? Suppose,
yes,
suppose you're not studying antibiotics. Is there a role of surveillance cultures?
Yes, sir.
Yeah. So I'm just bringing out the point for you to highlight that we don't do surveillance cultures routinely in our ICU. In vast majority of patients, we don't do them, and it's discouraged that you do all these cultures. But this is one of these indications where surveillance culture is indicated, and a prophylactic antibiotic is not indicated routinely in all patients. Of course, you did tell us where it is indicated, but otherwise it's not routine indicated. And in whom you do surveillance cultures, and even whom you've started to decide whether you need to expand and add antifungal, you'll do surveillance cultures. That's something. But I'm just going to look at this and say that you've started albumin. And why did you start albumin?
Sir, hypoalbuminemia related third space loss, and I was not able.
And you're thinking in terms of HRS use, I mean, elevated creatinine you said. Okay, fine.
Yes.
Why are you using Lasix as well as noradrenaline? Is it counterintuitive? I don't know. I want to understand the rationale.
Sir, actually, the urine output was 30 to 35 ml. My MAP was maintaining around more than 65 with the help of my vasopressor support. So, just to give a Lasix challenge, and then we started on Lasix, sir, to see if the output improves with the help of Lasix.
Okay. In a patient with hepatic encephalopathy that you're treating, with acute liver failure with hepatic encephalopathy, if you have these elevated creatinines and the urine output is low, what will be your modality of approach to these patients? Would it be the
CRRT, earlier CRRT will increase,
why CRRT?
will clear ammonia, sir.
Clear ammonia. Okay. Anything else? Why not hemodialysis?
So there is rapid osmotic shifts in patients with hemodialysis when compared to that of CRRT. And CRRT offers a more continuous removal of the ammonia. So there is a less rebound risk for the cerebral edema to happen when compared to a patient who is on hemodialysis.
Okay. Dr. Shiva?
Yes, I think that's fine,
Okay.
sir.
Okay. Next.
Yes. Sir, on day 2, the urine output stayed around 30 ml per hour. We did a CT of the chest, abdomen, and the brain. We reserved around 4 pints of FFP. And as the TLC was worsening, we added teicoplanin for MRSA coverage. The CT chest was suggestive of pulmonary edema with active infective etiology. So the probable source for our case was the lung in this case. So the reports, the TLC count was worsening. The platelets stayed about 0.45,000. The creatinine and the INR and SGOT and PT continued to worsen in our patient. The bilirubin levels stayed elevated. The ABG was still suggestive of metabolic acidosis with lactates around the same level.
You've used 4 pints of FFP, no? Was reserved or was it used?
No, sir. We only reserved it, sir. We didn't use because the patient was not actively bleeding in my case. So we only reserved it.
So when will you use it? Of course, when you said when the patient is actively bleeding. Otherwise, if the INR goes up, will you use them?
So
Suppose
ideally it is
Not indicated, sir. Only during invasive procedures, or if there is any bleed, then it is indicated.
okay.
So you do an invasive procedure, like for example, if you're placing a central line in a patient with ALF, do you give FFP?
Sir, actually, it is not indicated because it is a state of rebalanced homeostasis. In the synthetic function of the liver is reduced, so there is a reduction in both the anticoagulant and the procoagulant factors.
Okay.
So in this case, there is no active role of
Yes.
correcting the FFP before putting a central line or an arterial line.
If at all I have to give FFPs, what condition would I give?
Sir, active bleeding, or if I want to place an invasive device monitoring for cerebral edema, these are the two conditions that come to my mind.
Or do I do anything, any investigations to evaluate?
Sir, TEG or ROTEM can be done in these patients.
Viscoelastic, those things, tests can be done and then decided.
They will give us a clearer picture of whether to give FFP or not.
Any other reason why you will not give the FFPs?
Sir, the prognostic indication of an acute liver failure is dependent upon the INR levels. So if I correct the INR in these patients, then my prognostic index will fall. The MELD score will fall. The patient onto the liver transplant, the list of the liver transplant, my patient will come down. So it is not.
So that's very right. So importantly, to tell you first, I think what you said was right. It both procoagulant and anticoagulant are balanced out, not indicated unless bleeding. But most importantly, this helps to prognosticate. This helps to prognosticate and tell you whether the patient can go in for a liver transplant or not. So that's and if you give it, the listing will not be possible. That's something that you brought it out, and I just want to highlight that that's a very important point why we don't routinely give these patients. Of course, volume overload is also there. No, when you have volume overload in these patients, that's again a problem for these patients. Okay, Dr.
You've
Shiva,
done,
anything?
yes. You've done a CT brain to evaluate the patient is having a cerebral edema or not. You already have done ONSD. Do you have any other tests to actually evaluate this bedside?
So transcranial Doppler is one of the non-invasive modalities in which we look for the transtemporal. We place a phase array probe. We look for the middle cerebral artery velocity. And based on the pulsality index of the middle cerebral artery, if it is more than 1.2, then it indicates that we are dealing with a high increased cerebral perfusion pressures of more than 20 mmHg. And less than 1.2 being less than 20 mmHg of intracerebral pressures.
Okay. So you have also done a CT abdomen. Why you have done a CT abdomen in this patient?
So to rule out, actually, because of the leukocytosis was worsening despite the broad antibiotic coverage. So we actually did a CT chest and a CT brain and the CT abdomen to look for any infective cause in this case. Sir.
Okay. So one more thing, when you're assessing a patient on, the patient is already on intubation, right? For this patient, what was your sensorium? How did you assess the sensorium in these patients?
Sir, initially the patient was not sedated.
Okay.
So I first looked if he is responding to if he is waking up on call. When he was not waking up to call, I tried to stimulate him with some amount of pain, and then he opened his eyes. So my GCS there become E2. And then I gave him some pressure on the sternum to assess his motor response. He was firstly not obeying my commands. So then I looked for a withdrawal or a localizing response to that. So he was not localizing to pain, but he was more sort of withdrawing from the pain, flinching his eyes and withdrawing his shoulders. So that way my GCS came out to be E2.
No, when you assess this patient first, because the patient was already intubated. So is there any other way where you can assess the GCS of an intubated patient? Something, if you, it's like some score or scoring system.
Richmond agitation.
No, that's first time when you assess a patient on a ventilator or something like that. You have something known as a force score.
Yes, sir.
Yeah.
Useful in
Which is similar to GCS, but not exactly that. It has something like your, I think, respirations and brainstem, these things are there. So, so that is the reason why you actually have a better response.
Yes.
Yeah, we can go to the next slide if sir is okay. I think sir is not there. Okay, fine.
Yes.
Okay, please, let's go to the next slide, please.
Sir, on day 3, the urine output of the patient had reduced to 10 to 15 ml per hour. The shock in my case worsened. The noradrenaline increased now to 1 microgram per kg per minute. The vasopressin was at 0.03 units per minute. As the shock was worsening, the urine output was decreasing, and the elevated creatinine levels. We took a nephrology team consultation and initiated the patient on CRRT, and anti-edema measures were followed. The sodium levels came out to be 142 with the 3% NaCl that we were giving. The potassium was also on the higher side. It was 5.6, which prompted us to initiate CRRT at this point. The TLC trend and the INR and the OTPT trend kept worsening on day 3, and the bilirubin trend also was worsening on day 3. The ABG was still suggestive of severe metabolic acidosis, and the lactates kept on worsening to about 17, sir. Till day 2, it was 13. Now it was 17 in this case.
Can you actually go to the previous slide? A previous day also, you had a high lactates, you had borderline urine outputs, metabolic acidemia was there. Did you consider anything else? Did you consider any bicarbonate infusion, or did you consider any dialysis at this point of time?
Sir, patient was on bicarbonate infusion actually, sir, we didn't mention it because in the day one, the pH levels were 7.14, and
Okay.
then it improved. Bicarbonate also improved because of that, but satisfactory response was not there. Then actually day 2 or day 3 we could have considered to initiate CRRT, sir.
Okay. That is what I also felt. Maybe probably
Hello?
CRT could have been initiated a bit ahead compared to your previous these things. That's what I felt.
Hello?
Maybe. Anyway,
Hello?
yes. Yeah, please, sir.
So Dr. Neeraj here. Good
Yeah.
evening.
Yeah, good evening. Please tell me.
Sir, regarding the as you mentioned that worsening of hemodynamics, shock is worsening. So did we consider adding any antifungal agent here? Because given the background of
Yes,
like
possibly. I think
yeah,
we
because that
can
can
consider.
happen. We can
Yes.
do that, and later we can even de-escalate if it is fair
Yes.
enough
If the
later.
cultures were negative,
Such
probably.
as a negative and all, because we have to cover liver being the
Yes.
area here. So that a point I wanted to mention.
Yeah, definitely. Yes. Dr.
Okay.
Neeraj.
Okay, sir. Okay, sir. Okay.
Yeah, please, let's go to the next this thing. No? Dr. Sandeep, next slide, please.
Yes, sir. Sir, on day 5, the urine output was around 5 to 10 ml per hour. The CRRT one session was done. The cultures now came out. The blood in the urine culture was sterile. The ET culture came out to be positive. It was suggestive of Pseudomonas aeruginosa, which was a carbapenemase with intermediate sensitivity to colistin. So antibiotics were escalated at this point to polymyxin B. The TLC trend and the creatinine improved a bit with the CRRT, but the INR and the OTPT kept on worsening in this case. In the following day, the patient condition was further deteriorated, and patient, despite all the resuscitative measures, succumbed to septic shock and acute liver failure. Sir.
Yes, it's unfortunate that your patient has worsened. But in spite of appropriate resuscitation, maybe I think there is a role of initiation of. So if let's think that this patient was hemodynamically stable, maybe there was a mild metabolic acidemia, patient's ammonia was somewhere around 80 or 90, patient was having encephalopathy. What else could you do to mitigate the risk or to improve the patient?
So, plasma exchange.
Okay, therapeutic plasma exchange.
Therapeutic plasma exchange.
Okay, so what would you do? I mean, like therapeutic plasma exchange, how does it help? And why are you doing it? And how does it help? And there are two different ways of doing it. Basically, single volume plex and double volume plex. So what is better? So I've asked 3 questions for you.
Yes, sir. Sir, actually, Plex helps us to remove the, with CRRT, we are removing the waterborne molecules, such as the urea and the creatinine. But when we come to Plex, we are dealing with the protein-bound molecules. So we are removing the bilirubin and the cytokines in these patients. So that is why Plex is important along with the CRRT in a case of acute liver failure. Apart from that, there have been trials which have suggested that double volume Plex, that is high volume Plex, is helps us to improve the transplant-free survival rate and improve the mortality in patients with acute liver failure. There was a trial which was published in Lancet in 2016, the Larson trial, in which they used high volume plex, around 8 to 10 liters per day. The standard volume of the plex which we use for other sessions is around 1 to 1.5 times the plasma volume, comes around 3 to 3.5 liters. But they used around 8 to 10 liters of plasma exchange in this trial, and they did the plasma exchange therapy once per day for 3 days. The therapy was done, and after 3 days, they looked at the transplant-free survival rate in this patient. They looked at the mortality benefit in this patient, and this was the only trial which suggested that there was a transplant-free survival rate better when compared to standard medical therapy, and there was a mortality benefit with high volume plex therapy.
I beg to differ on that because I think we have done, I mean, though ours is a very small retrospective study and AIG itself has done, in fact, it was published in 2024. What we found is that it was not beneficial. I mean, even a single volume plex is as equivalent to as a double volume plex or high dose, high volume plex. So probably we at AIG follow only a single volume plex for all the reasons you have said. Okay, so this patient is, you have initiated on anti-encephalopathy measures, you have initiated on, you have considered, I mean, let's think the patient is hemodynamically stable, not having any cardiac dysfunction. You have done what all things you have done, like anti-encephalopathy measures, you have started empirical antibiotics, you have given your therapeutic plasma exchange, and anything else you would want to do for this patient?
Sir, actually, the treatment of choice in a case of acute liver failure will be liver transplant. So,
Okay.
if that case, I would like to involve the liver transplant team in this case.
Yes.
Evaluate the patient based on the transplant criteria, which
So when do you when do you involve the liver transplant surgeon in a patient with ALF?
Sir, actually, when the MELD score is more than 10, it is an indication to involve the liver transplant team. When the hepatic encephalopathy grade 2, grade 3 only, we have to involve the liver transplant team. It has to be initiated early.
Why do you want to do that?
Sir, because in acute liver failure, the short-term mortality is very high. We do not
Yes.
want to waste the time.
Yes. So basically what happens is you get to know, especially in the acute and hyperacute liver failure, the I think the 24 to 72 hour window is very, very important, where you have to take a decision on the workup for the recipient, workup for the donor, everything has to be done. So that is the reason why they say as soon as the patient comes to your ER, you feel that the patient is having probably ALF. I think right from there, we have to consider initiation of the liver transplant consult. Okay, what are the criteria where you decide for a transplant, whether you're going for the transplant or not?
Sir, there are two criteria. There is a King's College criteria, which is the standard, and the other one is the Clichy criteria from France. The Clichy criteria indicates to initiate liver transplant when based on the factor V levels, because that is the only factor which is not dependent upon vitamin K. Vitamin K dependent is 2, 7, 9, and 10, but liver also produces factor V.
Yes.
So they have chosen factor V for this reason. And if it is less than 20% in an age less than 30 years, if it is less than 30% in an age less than 30 years. And then the King's College criteria, in which we have paracetamol and non-paracetamol based criteria are there. The paracetamol based criteria indicate the initiation of a liver transplant if the pH is less than 7.3, even if hepatic encephalopathy is not there, or the serum lactate levels are more than 4, or it indicates three criteria which has to be present, such as an INR should be more than 3.5, the bilirubin, the creatinine level of more than 3.4, and grade 3 or grade 4 hepatic encephalopathy. In a non-paracetamol based ALF case, the criteria are again different. This mainly chooses INR as the main factor for a liver transplant. If the INR is more than 6.5, it indicates an absolute indication for liver transplant. Else, there are 3 out of the 5 criteria should be present as age less than 20 years, age less than 10 or more than 40 years, non-hepatitis A, non-hepatitis B related etiology, or an idiosyncratic drug reaction should not be there as the cause of the acute liver failure. The bilirubin level of more than 18. They have again used an INR as the criteria of more than 3.5, and the jaundice to hepatic encephalopathy interval of less than 7 days.
Okay, so these are the, I mean, criteria for your transplant considerations. Okay, do you have any dynamic scores again for evaluation of progression or mortality of your patients who's admitted to your ICU with ALF?
MELDS is actually
yes.
a dynamic indicator.
Yeah.
MELD
And
sodium
anything else, which is commonly used in India. India, apparently, they advocate it very much.
MELD sodium scores.
You have heard about ALF early detection? or early dynamic, sorry, ALF-ED, ALFED.
No, sir.
So please read about that. Apparently, there's a Indian Society of Liver which actually says that probably you can consider this ALFED as a score for which is much more dynamic and which can be a better predictor and has almost around 90% sensitivity and susceptibility for your outcomes compared to the other scoring system, that dynamic scores. Okay. So you're giving your conservative management, you have initiated Plex for your patient, you have done all your anti-edema measures. Anything else you want to do? Any other supportive measures you want to give for this patient?
Sir, there have been trials on artificial and bioartificial liver devices also. Under the artificial devices, the first one is the high volume Plex. Apart from that, there have been albumin-associated dialysis systems, such as Mars and Prometheus is also there. But they have indicated that there is an increase, there is a betterment of the coagulopathy and the encephalopathy, but there is no improvement in the mortality benefit in the patient by using these two systems. But the only one with the mortality benefit was found to be high-dose Plex. And apart from this, there is bioartificial liver support systems. In this, they use live hepatocytes. So they provide both the synthetic function of the liver as well as the detoxifying function of the liver can be performed. So extracorporeal liver assist device has been developed, sir, but till now it is in trials and there is not much benefit as of now, sir.
Okay, so can you list me? I mean, you have a patient with ALF in your ICU. Can you tell me a routine test or what all tests you would do daily or test in a daily basis or evaluate in a daily basis for a patient who is admitted in your ICU? I mean, you have done most of the tests, but I just wanted for the case of a revision, so that because
Yes,
that is I want to emphasize on that.
Yes, sir. Sir, as the patient is on 3% NaCl, I will do a daily sodium or a more frequent sodium monitoring will be done to avoid the hypercorrection. The daily correction should be around 6 to 8 milliequivalents per liter. The prognostic factors need to be evaluated on a day-to-day basis. The INR needs to be evaluated. The bilirubin levels need to be kept in check. And ABG has to be done on a daily basis to look at the lactate levels. These are the three main prognostic indicators that would be important in a case of acute liver failure. Ammonia, once it has been done, it has shown that the trends of ammonia elevation are more important, and ammonia levels of more than 150 are associated with poor mortality in this case.
Okay. So, and anything else? You have done all these things, something else, any other supportive measures you want to give? Normally for regular patients, you would give, right? Regular ICU patients, you give. Huh?
Nutritional support.
Yes. Okay. What sort of nutritional support you want to give? You want to give total parental nutrition. You want to give patient is having hypoglycemia, right? So you want to give anything like that?
Sir, we are already supplementing D50.
Okay.
And in my patient, given that we are dealing with hyperammonemia, we can give protein restricted diet, but it is a double-edged sword because again, my patient is in a catabolic state requiring high protein requirement, especially my patient being on CRT, his requirement will go up to 1.8 to 2.2 grams per day. So protein requirement will be a matter of
1 gram per kg.
So I mean, usually, I mean, we don't have any protein restriction on any patients with ALF, unless probably, I mean, usually no. I mean, there's nothing like a restriction. So we usually consider enteral nutrition, but again, some surgeons don't prefer because when you have enteral nutrition probably taking up for surgery, it might be difficult. But ideally, we have to initiate enteral nutrition. It has to be like a normal, it's not like a low protein diet is never administered in a patient. Okay. So is there any role for, I mean, like for CLD patients, you give lactulose as anti-encephalopathy measures. So can we consider lactulose in these patients?
Sir, there is no evidence of the benefit of lactulose in a patient with acute liver failure. The
Okay.
ESL does not recommend using lactulose in a patient with acute liver failure. So the cause being is key in chronic liver failure, the hyperammonemia in the body is more a gut-driven pathology.
Okay.
And by giving lactulose, we are decreasing the gut ammonia levels.
Okay.
But in cases of an acute liver failure, we are dealing with the hepatocellular necrosis which is happening.
Yes.
So the synthetic function of the liver is already gone. So
Okay.
because of that, treating the gut ammonia will not help us because the urea cycle is only failing in my case. So the ideal measure for hyperammonemia in my case will be to start him on CRRT.
Okay, you mentioned urea cycle. So, is there any role for your branched chain amino acids in such a scenario?
I'm not sure.
No, not much of this thing. And one more thing about lactulose I want to tell you is if you are administering lactulose, it causes bowel distension. It becomes difficult for the surgeon, if at all, if they are taking up for the liver transplant. So that's one more thing. Like you're not supposed to go ahead with lactulose. One, definitely what you have said is 100% right. Okay. So any other supportive care you want to give?
GI prophylaxis, DVT prophylaxis, though we don't give because already DVT prophylaxis actually can be considered because these patients are at a procoagulant state. But it is rather than that, we can use the DVT pumps instead of actually starting the patient on heparin.
Okay.
Mechanical prophylaxis can be considered rather than an anticoagulant upfront.
Okay, so let's consider two scenarios. The thing is, patient is on day 3, patient is having probably an improvement in sensorium, and thing is the INR is coming down. His ammonia is also coming down. Would you consider any de-escalation or anything in this patient?
It shows that the synthetic functions of the liver are improving, sir.
Yeah.
Based on this, I can cut down on the albumin support that I have been giving in this patient. And NAC infusion, NAC therapy has actually no role beyond 5 days.
Yes.
So beyond 5 days, I would cut down on the NAC therapy also. I would not continue that as INR is improving. And the antibiotics, if the TLC was reducing, I would de-escalate the antibiotics. I would come down to probably any BLBLI, such as cefoperazone sulbactam will be more appropriate. Doxy has no role in leptospira more than 7 days, sir. So I would like to de-escalate that also. And
okay, let's think the patient has worsened. The sensorium is a bit bad. The sensorium has worsened, and he's probably having the cerebral edema is increasing, and probably you feel that there is some sort of a reversal is of the flows are there on the Doppler. So what would you do in such a scenario? The surgeon says he's posted for surgery today morning, and you assess, like for example, you are assessing the patient just before the surgery and you find that his sensorium is bad, and you have done the Doppler, which is showing the reversal is not there. So the reversal of flow is there, and or probably there's no flow. And the surgeon is insisting on the patient to be shifted out.
Sir, refractory intracranial hypertension, there has been studies on hypothermia and the role of indomethacin in refractory intracranial hypertension. But if it is an emergency, sir, it has no role. But only for patients with impending cerebral herniation, they have mentioned the role of hypothermia in these cases, role of indomethacin in these cases. But there have been trials, but there is no actual survival benefit with the use of these two therapies also, sir.
Okay, so basically what I wanted to tell you was, I mean, what are the contraindications for a liver transplant? Can you just tell me? That was the issue which I wanted to ask.
Yes, sir.
Somebody wants
Sir,
to take up for surgery, for a liver transplant surgery. So
intracranial pressure of sir, an ICP of more than 50 mm Hg a cerebral perfusion pressure of less than 40 mmHg is actually a contraindication for liver transplant. We
Okay.
cannot go ahead at these stages. Apart from that, AIDS-related infection,
No,
any
AIDS-related, no, don't say that,
complication.
because AIDS is not a contraindication. HIV is not a contraindication for this thing.
Any hepatocellular carcinoma which has metastasized outside the liver,
Metastasis is one thing.
any hemangiosarcomas, any apart from this, yes.
If somebody has a significant ARDS, not
Yes,
even,
yes.
uh,
Respiratory
medical, or
failure,
probably
one,
somebody who's having a significant, like your patient was having a severe LV dysfunction.
yes,
So
yes.
probably in such a scenario, somebody who's requiring some sort of mechanical circulatory devices, malignancies, all these things, it is not indicated to go ahead with the liver transfusion.
Yes.
Okay, so I think that's it. Anything else from Dr. Durgesh you want to ask?
Yeah. So that is I think it is a quite elaborative discussion. So I think Dr. Dedipia is left because of his personal, and so like we have already like discussed elaborately what are the different causes of ALF in our Indian perspective. Like viral hepatitis is the most common cause. Then comes probably medication, mostly TB induced. Then probably there are over-the-counter medications what we use commonly. Then probably other infective causes we encounter commonly. So, and we are also seeing the what are other nutritional complication, other hemodynamic complication, metabolic complications, and the electrolyte. So specifically hypokalemia, hyponatremia, and especially hypophosphatemia also. Hypophosphatemia probably has a prognostic role. It will indicate that the probably liver is regenerating. So, and the one of the most common complication what we encounter is probably in grade 3, grade 4 hepatic encephalopathy, where there is a raised ICP, cerebral edema. So in that situation, so though ideally like ICP guided versus non-ICP guided ICP reducing therapies are has no role. But in this situation where there is cerebral edema, here we can consider with the EVD putting or ICP guided measures. That again, it is a gray zone, but centers where they practice commonly. So here again, nutritional wise also there is no thing that we should not restrict the nutritional. The nutrition should be optimized. Again, that there is no role for branch chain amino acid to give like. So nutrition has to be optimized, and again early involvement of transplant team. And whenever the patient receives or MELD score is around 10, so early involvement of the transplant is utmost important. So there's everything we elaborately discussed. What are the treatment strategies along the like conservative treatment, plasma exchange, high volume versus normal volume plasma exchange, role of the CRRT. So and the antibiotics when to optimize and all this thing we are elaborately discussed. I think any doubt from the audience? There is no
I think
question.
there is one question actually. Did you add the antifungal as a shock person? I think this was already asked. So Dr. Neeraj,
Yeah, already it has been discussed. I think it is worsening of the shock. Already we are in MRSA cover, adequate
Yes.
gram-negative cover. Maybe antifungal makes a sense in that situation. So that could be have been probably added, but I think I don't think it might have much of difference, but a point can be considered. So I think there are no more questions. I'd like to close the session. I would like to thank you, Dr. Shiva, for giving his valuable inputs. And I will thank you,
Thank
Dr.
you very much.
Dedipiria, for his input also. And I will thank my student, Dr. Afan and Dr. Sandeep, to bring out this wonderful case.
No,
And
let
I
me
will
tell
to
you
close
one
the
thing.
session.
Thing is, I think Dr. Sandeep has been exceptionally good. Probably
sir.
made my work very easy.
Yeah.
I just had to ask few
Afan.
questions. I think most of the questions have been answered really nice.
Yeah.
I had a very good discussion.
Dr.
Yeah.
Thank you,
Afan, sir.
Dr. Sandeep, as well.
Sir,
So,
Sir, Dr. Afan, sir, is.
Yeah, Sandeep and Dr. Afan. Yeah.
No, sir.
yeah,
Dr.
yeah.
Afan.
Okay, you're Dr. Afan and Dr. Sandeep. So I thought the name was, yeah, I'm sorry. Yeah. Thank you very much.
Okay, no issue. Thank you.
Thank you.
Thank you.
Goodbye. Have a good
Goodbye. Yeah, good night.